Hello, everyone, and welcome to the latest edition of our Unfiltered Productions podcast. And I have to tell you, this is the dead honest truth. We sat to a point that was not palatable for the public, and it was a lot of venting back and forth. And so we wanted to come in a good frame so that we could provide information with our, classic unfiltered nature. And so this one is about the RFI, about therapists being the start of care clinician, even when nursing is ordered. This is what's in the PPS proposed plan for 2025. An RFI is a request for information, and they're asking the public, that's you, if you're listening to this, you are one of the stakeholders in home health. Most likely you're either an owner, an employee, a clinician, and potentially a patient that's listening to this. And so that makes you a stakeholder. And one of the things that CMS wants, and I titled this, "Are You Serious?" They want to know that therapists, PTs, OTs, and speech are educated enough to provide the start of care visit. And I hesitate on that because I don't want to trigger Cindy again. And the current COP is very clear that if nursing is ordered, even if OT, PT, and speech are ordered, nursing has to do the start of care. There was a break from that during the pandemic as a result of trying to get as many clinicians to the house in a timely fashion. But then when the PHE went away, it went back to the standard definition of who has to do the start of care. So, Cindy, tell me about the now 3-week delayed reaction to this when you read it.
Well, the initial reaction was unfortunate because I was actually alone at the time. My husband was out of town. You were out of pocket. And so let's just say my pets got an earful of my initial feelings about this, because it's been a while since reading. I mean, there's always something in there about there's going to be a payment reduction. And we're not saying that that's not a serious issue. Trying to do the care we need to provide to our patients with less money is difficult. And it's frustrating that it goes back to issues around behavioral adjustment. And that's been years of going back and forth and pending lawsuits and all of that. We're not downplaying any of the seriousness of the rest of it. But to just pop up in there with this whole, we should kind of revisit the COP and make it possible for therapists to do that comprehensive assessment initial visit, and make it work differently. But then to lay out the list of questions, questioning our educational background, what kind of in-services and mentoring are done, what would be the impacts of this. And I just sat there going, you've got to be kidding me. Because let's just take current state. Let's not talk about the PHE for a minute. Current state. So if the word nurse is not on the referral, I am deemed qualified and competent to go out there right now. I could walk right off this call with order in hand, and I can do that initial visit and the comprehensive assessment, and nobody blinks an eye. And to do that, I have to follow all of the required elements related to the comprehensive assessment and initial visit is outlined in the COPs. So current state is I'm qualified unless the word nurse appears on the referral, and then suddenly I'm not. To the point where you want to now examine my professional education. You want to examine all of these. And it's kind of like, wait a minute, hold on. How did I suddenly lose my ability because of the inclusion of nurse on the referral? Because in reality, the referral lists out these potential services. None of them have seen this person. So it's kind of like, wait a minute, why would you question my ability in that situation? And then you throw on top of it the PHE. So the waiver situation said, okay, we got to get all hands on deck. We're going to put a pause on this. As long as, you got your orders all in place, therapy can go. So in other words, they already had their demonstration project. We did it for months, and their own data indicates there was no negative impact on quality. We didn't see numbers tank. We didn't see patients skyrocketing back to the hospital because therapy messed up the start of care. So we already demonstrated we can do it. We already have the ability in a case where there's no nursing. why are we even having this conversation? It seems like a simple fix. And even, Sherry, the preamble to that part in the proposed rule basically says people kept asking about this.
Yeah.
Well, I know K&K with some of the people that in the rule cycle said, oh, and by the way, since this didn't cause the world to end, can we keep doing it? I mean, it's not saying that therapy is now going to kick nursing to the side and demand we do all the admissions. We're simply saying that flexibility is in the best interest of the patient. And that we know that situations where, let's say it's an orthopedic case, Sherry, and nursing is ordered and so is therapy. And let's say the therapist is available this afternoon to admit them. The nurse isn't. The patient has to wait till tomorrow when nursing is available to do that admission that could have been done today. So this doesn't make sense even in those more therapy sounding cases when nursing's involved to continue to do this.
Well, and in that particular example that you're giving, there's so many more outpatient surgeries that are occurring. So this patient is coming home with brand new medications. They're coming home with the complicating factors of their comorbid diagnoses, all those things. And one of the explanatory things in the proposed rule about why they're asking for more information is they didn't get enough feedback from the pandemic. I think that's across every one of the PHE waivers. I don't think anybody was in the position during the pandemic to provide feedback on a technicality or a rule. And I think a lot of us, and a lot of us professionally, have kind of tried to put that pandemic period from 2020 to 2023 into a nice little box and deposit it in our head in the back corner where we don't have to think about it on a day-to-day basis, because it was traumatizing. It was traumatizing to the healthcare industry. It was traumatizing to our patients. It was traumatizing mostly to healthcare workers. And I think that one of the biggest concerns I have with not making this the law of the land, that whoever is on that referral can go out first, you know, like we did during the PHE, like you mentioned, is that the access to care has dropped off so quickly. The timely initiation of care has dropped off significantly since the pandemic and since before the pandemic. And a lot of things are getting in the way of getting a professional into the home in a timely fashion, notwithstanding the nursing shortage, for crying out loud. We are in a once in a lifetime nursing shortage in home health and all other areas and facets of healthcare. So, Cindy, what do you think caused this? Why do you think they're asking for more information?
Well, before we go there, you hit on a key point, because that was also in the same rule. This discussion about timely initiation of care and another RFI about why do you think you can't get out there fast enough? Oh, I don't know. Not being able to use my therapy like this could be part of it. It was just so like, did you read both parts together? Because I do think there's some overlap. But, you know, after we kind of decompressed a little bit and thought about it, we have to also be introspective and say, why would they be questioning our education? Why would they have such specific questions? And then we started thinking about and talking to some of our therapy peers. And that discussion was difficult, because what we have to admit is part of our respective therapy professions don't want to do the admissions.
100%.
They complain about the admissions. They've convinced their agencies and anyone that will listen to them that they should not be doing these on complicated medication patients. They should not be the first one out there unless it's a very cut and dried orthopedic patient. I think part of it is this term that I really wish we would get rid of, is a therapy only. We don't call a referral that comes for nursing only. We say, okay, there's orders for nursing, and if nursing finds the needs for other things, we get those orders, we move on, everybody's happy. Why we call these things therapy only, I think, has created this nursing exclusion idea that adds to the confusion from CMS. Because it sounds like if I order it for therapy only and they go do the admission, that's because they don't need a nurse. But there's many times we go out on a therapy only and, okay, they do need a nurse. But again, we have peers that see that, get in that situation, and raise hell. I'm sorry. The intake should have screened it better. I shouldn't have been the one doing the admission. Now I got to do all this other stuff. And it's like, wait a minute, hold on. Nursing, when they're ordered and we're not, and finds a need for us, adds us. That's all we're doing on the other side. That's part of doing a comprehensive assessment, is to say, in good faith, the order came with these disciplines, but I comprehensively assessed you and realized you have needs for other things. So I think some of this tantrum, unhappy behavior has created in the minds of some, maybe they shouldn't. They shouldn't be dealing with ones that don't come in a nice therapy package, that nursing really needs to vet it in a more comprehensive way. So I think we're getting bit a little bit by that. And I have a family member who is a PTA in home health. And when I talked to him about this, he said, do you know how many PTs complain when they have an admit? They're very vocal about this. And I'm like, okay, so if we're going to say, are you serious? And kind of tongue in cheek go, why on earth is CMS asking these questions when they have evidence? I think part of it is some of this I can't has become part of the mindset that we can't. So we have, and I'm using the collective we, have been part of the problem that has led us to where we are now, where someone's saying, okay, I get it, you can do it on a knee replacement. But if this person has CHF and nursing in you, why should you be the first one out the door? You've told us you can't handle that.
Yeah, and it's kind of like a game of not it, right? Not it. Therapist, not it. And you know, I look at some of the educational requirements, Cindy, and we have to call that out and call that out of part of the lunacy of this RFI. None of the therapy disciplines, OT, PT, and speech, can get out of school and start treating patients in home health without at least a master's degree. And I say that your new clinicians are at least a master's degree in OT. Most of them have doctoral degrees. That means they've been in school for at least 5, maybe 6 years. And during that schooling, they are taught basic life-saving techniques. They're taught how to recognize somebody who might need assistance of 911 or something along those lines. It is a full part of our education. And Cindy and I are both therapists. I'm a PTA, Cindy's a PT. And we had to go through that in our schooling, and we must keep those credentials current in our schooling. There are things that have happened in care of nursing and healthcare that are different. The minute you walk out of school, things change. Right. Maybe, you know, the minute your feet hit the pavement to go work, all of a sudden certain things have changed and we don't do certain techniques anymore. I mean, when I got out of school, we were putting every wound that you could ever see in a betadine whirlpool. Every one you ever saw. Let's dry that sucker out and it's going to heal. Those you had to do your CEUs. Right. That's why CEUs are required. If you're in home health, I'm sure you've taken advantage of home health specific CEUs. So it is really kind of an insult when you start comparing the number of years of education of the therapist and what they learn in school and being able to properly assess somebody for homebound status. When you have nurses, and this is no offense to nurses, I love nursing. I think that it's one of the least valued, but should be valued professions in the country. However, you can have an AA or an AS RN, which requires about 2.5 years of school versus 5 minimum. And that's one of those things you go, okay, yeah, more specific to medical health issues. Absolutely. There are a lot of BSNs and a lot of MSNs and ARMPs that are working in home health. I get it. I would want somebody like that to treat my very sick elderly relative. Mm-hmm. But that doesn't mean they can't go out and see him for and do the initial assessment for how sick they are. I mean, in home health, let's talk about it. Very rarely does that patient look like what they look like on paper when we go into a house. Is that a fair statement? And it's more about getting a healthcare professional to them. And I think that we can't push that notion enough. And so, Cindy, did you have anything to say about that aspect of this?
Well, I thought it was interesting, and I did bring it up in some discussion specifically with American Physical Therapy Association folks, is that they referenced the APTA ahead of those question lists, that they had investigated and learned about the educational background for those 3 professions, but mentioned APTA by name. So to do that and then ask those questions, I think what really needs to happen is we have to become vocal in this comment period. Professionally vocal. If you're annoyed, have your tantrum. Don't put that in there. We don't want that. But really thinking about, they don't want to hear it from the professional association, quite frankly. That's my opinion. They don't want to hear it from a professional group anymore. They want to hear it from providers. They want to hear it from therapists. They want to hear it from nurses. They want to hear it from patients. They want to hear real life does this work in the day-to-day operations of home health agencies? What are positive stories about maybe the therapist went out and, yeah, okay, right now it's a therapy only, but they discovered a significant health issue and got nursing involved, or sent them to the ER and saved their lives. I mean, those speak to that skill set. Now, some of our peers may want to get on there and say, I agree with you. I don't want to do admits. We got to drown them out. We don't know. There's going to be some in there, you know.
Here's the thing. We have to be prepared that there are going to be those therapists that say, I am not qualified. And that's a self-sabotage, in my opinion. And I know how you feel about that. It is a self-sabotage if you're going to not bring yourself fully professionally to this setting. And I say that there is education out there that you can get that is on demand, that's freaking free on YouTube for things that you may have a deficit in. And that goes for nurses, that goes for medical social workers, that goes for every professional clinician in home health. Home health is its own unique setting that has its own unique needs. And so that continuing ed part of it, you're responsible as a professional to have it done, to get it done and get yourself up to par, or your agency is responsible to get you up to par, which is why I understand the education piece. Sorry.
No. My issue is very specific here. There is scope of practice, which is the legal boundary of the entire profession. And then there is my ability as an individual PT. So the problem I see, and I've seen this for more than 2 decades that I've spent in this space, is when anybody, regardless of discipline, takes their personal skill set and uses it for the entire profession. So let's just say we know that wound care is allowable in many states for therapists to be involved in. And maybe I'm a therapist who hasn't done it in a really, really long time. It takes a lot of professional integrity to say, I'm not good at that.
Exactly.
I'm not. So either I need to go get myself the education appropriate to do it, or I need to disclose that I personally, although I'm a licensed PT, do not feel I am competent in that area and should not be doing it. When we say PTs can't do that, or that's out of scope, now you've overreached. You're taking the whole profession with you. And there are boundaries. I can't do surgery. I'm fine saying that. It is not legally allowable for me to do that. But I see a lot of this blurring, especially as we work with individual agencies, where therapists say PTs can't do X or speech therapists can't do Y. Your personal skill set is not interchangeable with scope of practice. There's 100%. A lot of things, and that applies to nursing, physicians. I mean, there's a lot of things you can do within that license, but what you're comfortable and competent in. So if this is an issue of I'm not comfortable doing a start of care on a complex medical patient, then it's one of 2 choices. I get comfortable by seeking mentoring and education in the different things they listed, or I disclose that so that the agency does not send me on one, but don't say I can't do it. Don't take a step out with that.
But wait a second. There's this word in the COPs. It's a lot of syllables. I understand. It's called collaboration.
Right. We can
talk a little bit about that with regards to the SterCare Oasis. That
is in getting insight of different people that are coming in. So let's say it's a complex medical patient and I feel that I'm proficient as a PT. I go out there and I realize, no matter what that piece of paper said, I'm over my head. Okay, this is way more complicated. So what am I going to do? I'm going to call the office. I'm going to say, listen, I know we have an order for nursing. We got to get nursing in here sooner, or we got to contact the doctor. These are the steps we're going to take. And then, you know what? There's part of this Oasis assessment. You know, I know what I'm thinking, but I know the nurse is coming right behind me. I want to talk to them after they do their assessment and be able to do it. This is more, Sherry, you're really poking the bear here. This is more than just therapy evals used to double check nursing functional assessment. That isn't even collaboration. That's not them talking to each other. And collaboration means if I'm seeing what I think I'm seeing, but someone else is coming in after me in that appropriate time frame, we can talk about it. I'm the final decision maker because my name's going on it, but I can seek out that input. So the idea that I can't do these unless I am 100% confident, I know everything all the time, every time, never going to happen. And I'd be scared if anybody ever said it. But I think that comfort level is where some, I don't know if, or I'm not good with. it just gets blanketed in, I'm not allowed to do that. It's my license will burst into flame if you send me to do that. And I think these need to be more professional conversations with our peers that might see this as a negative. I don't want to do that, that nursing should be the one doing it. As a matter of fact, we still deal with agencies, Sherry, that put nursing orders on everybody no matter what, because that's what they think needs to happen. So they're writing off free nursing care in a shortage situation. That makes no sense. So I think it's a good conversation, but I think we have to use that comment period, because their thing of we didn't get a lot of feedback. It's like, hold up. You had your demonstration project. If you think you still didn't get enough feedback, you need people actively out there doing this work to tell you why this makes sense to do it. It doesn't cause extra cost. It doesn't cause financial burden. And I think we need to be spelling out, this doesn't mean therapists want to take over all the admits. If this is a complex medical and nursing is available, I'm not going to go knock her down so I can do the admit. We're not trying to take over anything. It's simply that if an agency is going, who can I get there first so that we can get eyes and assess the situation better in real life, not paper, then let's do this.
Well, and I'm sitting here right now while a tropical storm heads over my house, and it's north of us, but we've had rain now for almost a solid 2 days, and I know that there's roads in my area that are not passable, and this is what it comes down to, the brass tacks. Somebody in my area that I could reach as a therapist. Now I'm a PTA, Cindy's it's a PT, but if I were a PT, OT, or speech, I might be able to get to that patient on the first day post-surgery while the nurse could not because of a blocked road. What's better for that patient? Here's the thing that I want agencies to remember. You still get to make the choice in your agency who goes to the house first. You still get to make that choice. That is not being taken away from you. This is just allowing you more options. And I think that's how you kind of have to look at it. You have to say, okay, I need as many options as possible in the worst case scenario to make sure my patients are safe. And by doing this, by saying, wow, this is kind of crazy, you're asking for this, it's great. I think it's a great idea that we have those options in home health. But I also want to bring up something else. Anecdotally means it's a bunch of random opinions, not really a study. I actually queried our reviewers, our Oasis reviewers in K&K. We outsource for a lot of big companies across the country, and we outsource for the tiny companies across the country. And I asked them, anecdotally, who does a better start of care? Which one of them requires the least corrections? And to a person, they said the therapy ones. Why? I don't know. But that is something that we need to take into consideration and think, who's the best person? Who's the most detail-oriented? Who is that person that's going to get the most information when they get in front of that patient to start that collaborative interdisciplinary care conversation and that team conversation? Who are those individuals in your agency? Right now, some are eliminated based on, as Cindy likes to say, a word that's written down, based on RN, and or nurse, So thinking about that from your agency perspective and how that can protect you in a way, does that make sense what I'm saying, Cindy? Is super important. So as we're approaching that 22-minute mark, I wanted to know if you had any closing thoughts, and just a reminder, everybody, the comment period for the proposed rule ends on August 26th at 5 p.m. Eastern. Have all your folks send in information on this. I mean, literally ask them patients for the difference if they notice the difference. I know I've asked some of my reviewers to write a comment to say, hey, we've noticed no difference in the quality, or actually better quality when we review a therapist doing a start of care. That stuff is all relevant. So let's give them all the information they can. Go ahead, Cindy. Sorry.
No, I would absolutely echo that, because I think if we go, well, this is kind of silly, it's obvious, we have the PhD and they get the same 5-6 comments they've gotten in the past, it may not move the needle. And no offense to the professional groups, but I think to cite them and then ask the questions anyway, you're looking for the grassroots. You're not looking for a well-crafted statement of what our educational programming is. You want to know, what does reality show, and really what will that flexibility do for your patient care? And that's really why we wanted to do this after we calmed down a little bit about and admit our professions have been part of the problem. Okay, we understand that. But now we have an opportunity through this RFI comment period to really try to put this issue to bed. and then be able to say, okay, now we have flexibility. We're not handcuffed to that anymore. And then revisit, how are we really organizing and making those decisions within our agencies?
Cindy, I appreciate you closing that out. And I just want to remind everybody that this was the calm version of this podcast. And so if you want us to get fired up about any subject, if anything's on your mind or any argument going on in your agency, please reach out to us, because we'd love to comment on it. And please take a moment to ask everybody that's involved, every stakeholder, patient, clinician, staff member, reviewer, anybody, to make a comment on this proposed rule, because you have to say something in order to have a say in something. So thank you guys so much for listening, and we'll see you next time on our next Unfiltered. Please be safe out there.